Así que, bueno, buenas noches a todos. Muchas gracias una vez más por estar aquí con Víctor Bracho y todo el equipo de CMDLT de Venezuela, de Caracas, haciendo esta serie de webinars de la Sociedad Interamericana de Endoscopía Digestiva. Y en esta ocasión estamos con Edward Despott de Inglaterra. Edward es un amigo que además ha apoyado muchísimo todo este camino de la CIED y estamos muy agradecidos. Víctor va a presentarlo apropiadamente, pero quería hacer esa mención. So, we are here once again, Edward, with you as a friend of the Inter-American Society. Thank you very much. Victor is going to make the introduction and your presentation, but I want to thank you especially from here. So, welcome everyone, and here we are. Go ahead, Victor. Thank you.
Hola, hola. Hola comunidad CIED, es un honor nuevamente estar con ustedes esta noche. Hoy tenemos al profesor Edward Despott. Edward es gastroenterólogo consultante y endoscopista intervencionista de la esfera gastrointestinal. Él es profesor asociado del Royal Free Hospital de Londres, Reino Unido. Dr. Edward Despott is a consultant gastroenterologist and interventional GI endoscopist. He's an honorary associate professor from the Royal Free Hospital, London, UK. Edward, okay, the cameras are yours to talk. Welcome.
Thank you so much. Thank you, Asador, and thank you, Victor. It is a great honor and a pleasure to be here with you this evening, and I also wish to say hello to all my good friends, both in the Americas, but also all around the world. And thank you for joining, really. It is a great honor and a pleasure, especially in these crazy times. So I'm going to try to start my presentation.
Mientras tanto, por favor, les pedimos a todos que pongan los micrófonos en silencio para que no haya acoples de sonido.
So, can you hear me? Can you hear me all right?
Yes, perfect.
Okay.
Yes, perfect.
Fantastic. So I've been asked by this lovely society to talk about the endoscopic management of colorectal mucosal lesions, and this is very broad, from cold snaring to ESD. So I'm going to take you through a journey tonight, and then we'll have some time to discuss things in great detail. These are my disclosures, but I think I would be mad not to recognize the crazy times we're living in. A tiny, minuscule agent has really flipped our world upside down and stopped life as we know it, and the whole world is still at war with this crazy virus, and it has hit London very, very hard, as chronicled in this BBC documentary, for example, which you can access over the internet. Our hospital in central London was one of the hardest hit places, and this really documents its experience and how we battled it and are trying to reopen and restart our services, because the pandemic not only has hit us directly, but it has also taken over all resources, and this has had an impact on the usual diseases that we manage, like the ones we are going to discuss today. So it has had a double whammy, and nonetheless also a triple whammy, because it has also affected us through a psychosocial and also economic front. And I'm very hopeful that we will soon move away from having to practice like this on a day-to-day basis. I don't know when this will happen, but a few months ago, we would have never thought that this is going to be us in our day-to-day practice. No, this is not a set of photographs from the space station. This is us in our endoscopy unit at Royal Free Hospital on a day-to-day basis. Absolutely crazy. And as endoscopists, we've also had to think about making our own protection materials, because of course these have become an extremely valuable resource. This is us making our own face shields and using simple, readily available materials. And because aerosols are an extremely high risk to this COVID-19, we have also tried to mitigate the risk by making these little devices through the use of 2 surgical masks to reduce aerosol spread during upper GI endoscopy and the like. And this is it in practice at double balloon enteroscopy. So all these factors trying to mitigate the risk against this horrible disease. And we hope that in time this too shall pass, and while we live in nostalgia for our normal recent past, it's only a few months since we were in Rio, Asador and Victor and Blix, but the world has changed so much, and although we have this nostalgia in mind, we shall continue to hope for a happier, safer and brighter future, so that the world that has been flipped upside down will come back to normality. And this is the Royal Free Hospital, my hospital, has seen to the beautiful Hampstead Heath in London, which I hope you can all visit once this crazy time passes. So back to my talk, endoscopic management of colorectal mucosal lesions from cold snaring to ESD. And I've elected to split this into 3 parts. I think before we move into the exciting and thing that we're all here for, the resection, I think we should focus on quality and lesion detection, because without a quality colonoscopy, we will miss things, we will not find those lesions which we need to resect to prevent a cancer from happening in our patients. So quality is key. Yes, all about quality. I can't say it enough. And in order to achieve quality, we need to go back to the imperative basics. So one of the key imperative basics is actually bowel preparation. We need to have a clean bowel, because otherwise we are not going to be able to see those lesions. And even in a clean bowel, we all know that there are some tiny puddles that remain, mucus attached, and we need to wash off those things. And we are very fortunate nowadays in that we have most scopes equipped with a water jet channel and these water jet pumps, which are quite inexpensive, but very, very effective. And I don't think we have any excuses to be in a position where we have stuff stuck to the bowel wall and not removing it, because that stuff can actually hide a lesion which can potentially be fatal to our patients in the future. Another key imperative basic relates to position change. So as we know that position changes can help us during the insertion of the colonoscope, the same position changes help us to get better views of the bowel wall. So for example, if you have your patient on the supine position, you get better views of the transverse colon, and so on and so forth. So really practice this, because it is quite important to maximize views. And of course, use your best instruments. Nowadays, we have high definition endoscopes, and definition is also akin to resolution. And the definition of high definition is that the scope, or the optics of the scope and the processor, are able to discern 2 objects as being 2 rather than a blurred one. And this indeed has consequences on lesion detection as well. So use your best instruments and invest in these things, because ultimately you're going to serve your patients better. Quality has been benchmarked by various societies around the world. We recognize that without a body of evidence and without consensus, quality can be talked about, but to achieve it on a regular basis, we have to set our benchmarks. This is the performance measures we look up to. We were involved in the creation of these, and these are the ESG and UEG performance measures for lower GI endoscopy. And I think it's worthwhile spending some time going over these before we actually move into the resection phase of our talk. And quality measures are divided mostly into three particular parameters. So there's the pre-procedure, which includes the bowel preparation and the time slot, and I'll talk a bit more about those. Then there are the procedure-related measures, including patient experience, because we sometimes forget about this. And then post-procedure, which includes surveillance, etc. So the pre-procedure performance measures relate to bowel preparation, and we aim to achieve a very clean bowel, so a bowel preparation score of over 6, and the aim is to achieve this in over 90% of patients, ideally in everyone. And this is what we're looking at, which discerns it in comparison to the others where you can miss lesions. Give time to your procedure. We all know that quality is not a friend of a fast procedure. The faster you are, the more likely you are to miss things. And the exercise here is not to complete 20 colonoscopies in an hour, but to have enough time to find those lesions and to resect. So allocate at least 30 minutes for a colonoscopy. And if you are suspicious that you are going to find a lesion, or if you know that there is a lesion, you should allocate more time, because as you know, therapeutics take longer, and you have to also bear in mind that not everything might go right, and you might need more time to actually deal with those things. So do not put yourself under pressure, allocate enough time for your procedures. It goes without saying that a complete colonoscopy is key. So it's pointless to do a colonoscopy that only reaches the transverse colon or the ascending colon. It has to reach the cecum, and it is a legal obligation to actually document this in many societies. You have to document your cecal intubation with a photograph or a video documentation, because this has medical legal implications as well as serving for a quality parameter. It's important that we actually strive to detect those lesions. So an adenoma detection rate of over 25% is what we aspire to. And if we consider all polyps, this should be hovering around a 40% mark. This includes hyperplastic and serrated lesions, which I will talk a bit about later. What about withdrawal? So we all know that many lesions are detected on withdrawal, and there was a famous paper many years ago in the New England Journal which first demonstrated that 6 minutes was the magic number. We now strive to achieve a longer time, because we know that up to 10 minutes we can achieve an even better quality in terms of lesion detection. Beyond that, it peters out. We need to understand that it is a duty of ours to resect those lesions. So if we find a lesion that's over 3 millimeters, we must resect it, and ideally by a snare. Because if we try to resect something that hovers around the 3 millimeter mark with a forceps, for example, we run the risk of leaving that lesion behind. It would be difficult to find the remnants later. It may grow into something worse, and cold snaring, as I will show you later, is very easy to achieve. So try to use a snare in most lesions. And if you find a lesion or you resect a lesion that is 20 millimeters or greater, you need to mark its place. And I'll show you how to do that in a few moments. And it is really, really important not to forget to do this, because number one, it will guide your surveillance. And number two, it will also guide your surgical colleague should the lesion contain an occult cancer, because marking with a suspension of sterile carbon particles is going to be critical in identifying the site of that resection. And this is us tattooing. We should also try to retrieve all polyps, especially if they're over 5 millimeters in diameters, and this obviously has its own understood sense into it, because we need to Number one, understand what the lesion was, whether it was an adenoma, whether it was a serrated lesion, and whether it contained high-grade dysplasia or even a cancer. So it is important to try to retrieve it. I know there are schools of thoughts and evidence suggesting that if you have a correct optical diagnosis, retrieval of polyps may be thought to be something that can be omitted, but the evidence still supports us retrieving these polyps, at least for the time being. And if you have access to it, especially nowadays that all scopes practically contain some electronic type of chromoendoscopy to enhance contrast, we should use it. And if you don't, you should also try to use something like dilute indigo carmine, which tends to allow you to detect and identify and even characterize lesions at a superior level. And we should all speak the same language when describing lesions. We should be using things like the Paris classifications in all our reports, because a polyp is a polyp is a polyp. And if you say polyp, no one knows really what you're talking about. The Paris classification, although sounds esoteric and potentially confusing, is very simple. And if one looks at it a few times or even have it in your endoscopy room, it is very easy to use it to actually speak the same language. Regarding complications, you should try to reduce your complication rate as much as possible. Ideally, you should have less than 0.5% complications, even if you are resecting lesions. And you should also monitor these and record them and audit them, because if you are or your unit is moving in the wrong direction in relation to this, you may have to take measures to correct it. And don't forget your patient experience, because it's not just about finding those lesions and removing them. The experience of a colonoscopy nowadays for the patients should be one of the gold standards we aspire to. And this is something we are very proud of here in the UK through the Joint Advisory Group for GI Endoscopy, whom most of you would have heard of, the JAG, as an affiliation with the Royal College of Physicians and the British Society of Gastrointestinal Endoscopy. We have developed this 12 patient-centered standard protocol, which relates both to the quality of the patient experience as well as the clinical quality that we were discussing before. And also, one should consider surveillance, because especially if a lesion is removed piecemeal, for example, surveillance is critical, because you need to catch that lesion recurring when it is still relatively small. It has implications on how you treat it. But also, if there are patients who are at risk of developing cancer, you need to keep them on the radar. And although the latest guidelines, both on this side of the Atlantic and also on your side of the Atlantic, although the guidelines are moving towards less frequent surveillance, we have to bear in mind that these patients should still be plugged in to the system and not allowed to fall away from the radar. It's critical that if the lesion is removed piecemeal, we still have to really keep a close watch within 2 to 6 months, and not later than a year, because lesions removed piecemeal are at particular risk of recurring. Other key points to consider about lesion detection: you should wash debris, as I mentioned before, use a water jet, and use Cymeticon. I wouldn't put the Cymeticon inside the water jet, because the water jet channel, if it is dedicated especially, can form a biofilm associated with Cymeticon. So if you are using Cymeticon, put it in 50 ml syringes, dilute it in water, and flush it through your standard channel rather than placing it in the pump. And this is what is recommended by most companies nowadays. When you see a small patch of mucus, especially in the right colon, assume that there is something hiding underneath it, and most often this would be a sessile serrated lesion. So watch out and wash that mucus plaque very carefully and look underneath it, especially with E-chromo or a bit of indigo carmine. And remember to change patient position. I can't stress this more. Remember to change position, because that can be critical in missing a lesion or finding it out. Along with changing position, I would consider also retroflexion, especially in the right colon. It is not something that is too difficult to achieve. Of course, you have to do it carefully, and the trick is to obviously push your big wheel down as much as possible, as you would in the upper GI tract when you're trying to look at the fundus, and gently advance your scope with a bit of anti-clockwise torque while moving your little wheel to the right as well and twisting it anti-clockwise. And like that, you can actually easily retroflex without much in terms of damage to the mucosal surface. Do it gently, practice, and you can achieve it. And that can allow you to look behind folds, especially if you insufflate, and to detect some lesions. And I'll show you a video of that in a minute. I have to spend a couple of minutes on serrated lesions. So as I said, this mucus cap is a very, very pathognomonic sign of the presence of a lesion. And then you start playing with chromo or e-chromo and you find it out. Look for an irregular surface with a cloudy surface and an irregular edge. And if you find a sessile serrated lesion, make sure that you understand its extent, and this can be achieved by injecting underneath it, which tends to show the extent of the lesion, especially if there is a bit of indigo calming in the injection fluid. And this is a very good review by Doug Rex and colleagues, published about 8 years ago in the Red Journal, and I would advise you to do it. Another point is the WASP classification, which is the classification of serrated lesions and how to identify and characterize them. This was developed by Evelyn Decker's group from Holland, and essentially by using narrowband imaging or interchangeably blue light imaging or even Pentex's eye scan, you can actually look for an irregular shape, an indistinct border, a clouded surface, and dark spots inside the crypts. And if you see several of these, over two especially, the chances are that you are dealing with a sessile serrated polyp. And sessile serrated polyps are not the benign lesions we used to think of them in the past. As you know, they may account for about 30% of occult cancer, especially on the right side, and they can be particularly difficult to detect. So keep an eye out for them. Do not miss them. What about ancillary technologies? You know, over the last few years, there have been several coming out, including endocuff, endo rings, the Fuse, which is the full spectrum endoscopy, and also the GI scope, which has an insufflatable balloon. And they sounded all like very good ideas, in that they move the folds around so that you can see more. And with the Fuse, you could see even on the sides. And there were several studies that showed that they may increase adenoma detection rates, especially in inexperienced hands. But a meta-analysis, which is really hot off the press, just in press actually, just now this month, in gastrointestinal endoscopy from Pradeep Bhandari, Alessandro Repici, and Cesare Hassan, leading the group, where they looked at 8 high-quality random controlled studies, including over 3,500 patients. And the conclusion was, at least in a bowel cancer screening program, that there was no real improvement in the detection rate of colorectal neoplasia, including polyps and cancers in fit positive patients, at least in a bowel cancer screening program. So I think if you train yourself well enough, you don't really need these things, albeit they might help less experienced colleagues. I can't say the same for the very short black hood. This is not something that obscures the view like a distal attachment we use for therapy. This is a very short black opaque hood, which can be improvised by using tape, and I'll show you in a second, initially developed by the Japanese. And this just keeps you about 1 to 2 millimeters away from the mucosal wall. And it allows you to enhance your ability to potentially intubate the colon to the cecum by keeping you away from the folds. It can speed you up as well. And I would recommend it, and it can be made by a simple piece of electrical tape. You fold the tape like so, and then this folded piece of tape can be stuck along the endoscope like so, and you have this literally 1 to 2 millimeter gap, which allows you to visualize the folds and avoid you getting a readout, especially if you use it with water immersion and something like near focus. Of course, the future for detection is going to be, for sure, through the world of artificial intelligence, and this is my dear colleague Alberto Moreno at our unit looking at the device by Medtronic, the GI Genius, showing him that there is a polyp, and this is when we launched it at our unit. And this is a tiny, tiny lesion, which has the GI Genius helping it on the left-hand side. And you can see that this could have easily been missed. But of course, the GI Genius is like a guardian angel sitting down on your shoulder and guiding you. And like the one from Medtronic, there are several coming out, and I suspect the future will hold that every endoscopy system will have its own version of artificial intelligence to help you. So moving on to the more exciting bit, the resection. So I'm going to talk a bit about cold snaring in the second part of my talk, polypectomy and endoscopic mucosal resection. And the learning objectives are that you should understand the lesion. You should also know how to prepare and set up the room for resection. And then we'll talk about the different techniques and how to apply them, but I'll reserve ESD for the last bit of my talk. We also have to know how to deal with complications, and we should not forget to mark for surveillance, as I said, and then we'll summarize. So I can't stress this enough. The Paris classification, very simple. It was first published in 2002, so almost 18 years ago. And this is something that we should use as an interchangeable language worldwide. It's very simple, so something on a stalk is a 1P because it's got a peduncle. Something relatively squashed down is a semi-pedunculated, so PS, easy. If it's flatter, you have a 1S sessile, and then the flatter it gets, a 2A is just a tiny elevation of the surface, and that can be depressed as well, so this is a 2A plus 2C. And then if it's really super flat, it's a 2B, and then we start worrying when we see the 2Cs on their own and the 3, which is ulcerated. And this is concerning. These are the things that can be most likely to be harboring a cancer. So it not only tells us about a description, but it also has prognostic implications, because an ulcerated lesion or the depressed lesion is much more likely to harbor something nasty. And of course, as a sort of variant of the Paris classification, we should also know the Japanese way of describing things. So this is called a granular tumor in Japanese style because it's got granularity to it. And these are very benign lesions, even though they might be quite large in the surface area, they are very benign. But if you see that there's something relatively smooth, which would equate to a 2A lesion, and sometimes with a 2C component, this is the non-granular type of lesion, and this is much more concerning because it can harbor neoplasia, which involves the submucosa, so submucosal invasion, as shown by Michael Burke's group in this paper, up to 15%, and especially if it's got a 2C component, which is a slightly depressed area here, the risk of submucosal invasion goes up very significantly. And this is a far cry from these granular lesions here, which are almost always benign with a very low risk of submucosal invasion. And if the submucosal invasion is going to happen, it will be in the nodule. So this nodule needs to come out en bloc. And this is a Japanese paper from Hotter et al. Showing the same thing, that the risk in non-granulars would be most high in the depressed area, although you can get multifocal neoplasia in a non-granular lesion. And if you're going to have a large nodule in a granular lesion, that is where the cancer or the high-grade dysplasia is going to happen. But it's not just about Paris morphology, it's also about the surface. And it was first Professor Kudo, a long time ago, over 20 years ago, who showed us that if you look at the surface and interrogate it, it was initially using crystal violet, now we use indigo carmine with a bit of zoom, you can tell the underlying pathology of the region. So this is type 1 normal pit pattern, and you have a star-shaped pattern, which is type 2 here. This is mostly in keeping with hyperplastic or serrated lesions. This, the type 3S, which was identified by Professor Gudo himself, is a strange type of pit pattern. It is smaller than type 1, but it can be very dangerous because type 3S moves in this direction to type 5 very, very quickly. Usually find these lesions, they could be quite small, mainly on the right side of the colon. It's usually a 2A plus 2C, and in the center you have a 3S, which rapidly moves into type 5. So if you see 3S in the center of a lesion, watch out. Type 3L is your usual tubular adenoma with low-grade dysplasia, and type 4, which is like the brain, the cerebriform aspect, is usually indicative of a villous component, and although still quite benign, indicates that there might be a higher risk of high-grade dysplasia inside the lesion. Type 5 is amorphous or irregular. It can be divided into type 5I or type 5N, and type 5N is really where you are going to have a definitive cancer with deep submucosal invasion. And this is what I was describing in situ. This is the 3S lesion. You can see that this is a 2A plus 2C, and this is a dangerous lesion. This is a serrated lesion or a hyperplastic lesion, and these are the cancers. And the Gudo classification has quite a high sensitivity and specificity, which hover almost around the 90% mark, which is quite encouraging indeed. We don't need to use dye spray nowadays. We've got the luxury of having inbuilt chromo endoscopy, so electronic chromo endoscopy, and this was the first one that was developed, narrowband imaging by Olympus, which then was also paralleled by this development from Fuji, blue laser light imaging or blue light imaging, and also LCI of late by Fujifilm as well, and iScan by Pentax. And what these things do using blue light most of the time is that they allow a higher contrast to develop on the surface for us to be able to see, especially with high definition scopes, which have a degree of zoom. There are several classifications. This is the one I use most, which is the Jaynette classification. So the Japanese NBI expert group sat down and elected to make a slightly more defined version than the NICE classification, which was the Narrowband Imaging International Classification, which only has one type 2 rather than 2A and 2B. And in this classification, type 1, easy, you've got a normal lesion or at least a type of hyperplastic or sessile polyp, okay? In type 2A, many a time you have low-grade dysplasia. In type 2B, it becomes slightly irregular, the surface, so you might have high-grade dysplasia. And type 3, which an amorphous state persists, is most likely to be a cancer. And this takes into account both the surface pattern and also the vessel pattern, okay? And these are the ones that can still be resected, and these are the ones that are definitive cancer. And why is it important to try to understand what a lesion is doing by looking at its surface? It is important in this part of the talk that is relating to resection, because of course the lesion morphology in the surface can dictate the submucosal or indicate the submucosal invasion. So if you had to divide the submucosa into 3 parts, SM1, which is the upper part, SM2, which is the middle part, and SM3, which is the lower part, these correlate with the risk of lymph node metastases. In SM1 being about 1 to 3%, while in SM3 going up to 23%, which is quite significant indeed. If you've got a peduncle, a polyp with a peduncle, you've got a bit of a buffer zone because you've got a longer submucosa there, and you may still cure a cancer if it affects the head of the polyp, but it is less so if the lesion is flat. And it's not just about predicting the depth of invasion. Understanding the morphology of the lesion allows you to pre-plan, to understand how difficult the lesion is going to be to resect, and also what is the risk of having complications. And this great man, Michael Burke, had come up with the SIMSA score, which is an abbreviation for size, morphology, site, and axis. And if you have a high SIMSA score, you have a higher risk of complications and also of difficulty and time to remove the lesion. Okay, so it is important to try to understand it. Moving on to preparation and setup. So always consider the patient as a whole, not just because you found a lesion that might be endoscopically resectable should you remove it. So you have to see the whole context. And sometimes clinicians who are also interventionists focus on the lesion and sometimes forget the bigger picture. You have to understand the patient's age, comorbidities, and the medications that they're on, because removal of the polyp might not be the right thing to do for that patient if you consider him or her as a whole. And in order to allow you to do this in greater depth and in a more holistic fashion, create your MDTs, multidisciplinary team meetings, so that the decision is taken by a board, and that allows for the best decision to be taken for the patient without bias, and it also allows for a degree of medical legal protection as well, I'd say. Always consent your patients and make sure that they understand the risks and benefits and the alternatives. Sometimes there are more than one way forward, and that would include surgery or doing nothing. So do not forget to discuss alternatives. And always, when resecting lesions, have a plan B and a plan C. Ensure that you have adequate surgical cover and the support structure. And don't forget to bear in mind what to do with anticoagulants and antiplatelets. Many a time with low-risk procedures, these things can carry on being taken, but if you're going to be resecting lesions, especially if patients are on the novel anticoagulant, so often you have to take measures, okay? About the room and about the preparation and the toolkit. So have a large room and make sure that your nurses understand what is going on and are planned and trained for a region resection, and also have dedicated lists with enough time. As I said before, time is critical, not only to find lesions, but also not to feel under pressure when you are about to resect. Of course, train yourself to have the optimal colonoscopy technique, because nothing is less satisfactory than a poor technique. And number one, you can do more harm. You can have higher complications if you do not learn to control those fine movements. And also you can harm yourself as well as having complications, because ultimately if you are using the wrong technique over and over and over again, you have a higher risk of developing repetitive strain injury to your muscles, your joints, and your cervical spine especially. And have adequate training, and if not, retrain or refer on to the expert who would be able to do these with less risk to your patients. And always, especially with therapeutics in mind, have adequate preparation, because that will impact as well on the complications that you may have. Choose your best scope, have a distal attachment, okay, a cap or a hood, and have diluted adrenaline in the room, not only to inject, but also to wash, because if you've got exposed vessels after you've cut them, you can actually spray this dilute adrenaline, and it allows you to get a drier field. Carbon dioxide is imperative to use, okay? Do not use air nowadays. It's unacceptable in this century to be using air. You should always use carbon dioxide. Number one, it is much more comfortable for patients because it gets far readily more absorbed. And also, if you have a complication, it allows you to have some more time if you've got a pneumoperitoneum, if you have carbon dioxide vis-a-vis air. Injection needles, 21 or 23 gauge, have your injection solution, and as I say, adrenaline washes. And not just one snare, have a range of snares, especially if you are going to be doing wide field EMR, because if you are doing wide field EMR, you might need a smaller snare to resect smaller portions. Have a coagulation forceps, such as the coag grasper, have clips on the ready just in case you need to close the resection site in the context of a large lesion on the right-hand side, or else if you have a perforation or a bleed. And always remember to tattoo and mark. This is our EMR solution. I usually use succinylate gelatin, which is a bit of a colloid, a bit of diluted adrenaline to keep a dry field, and some indigo calming. And this is an array of snares. Usually my workhorse is going to be either this hexagonal or this one, which is a serrated snare, but I also like to have smaller ones just in case I have a small area which I can't resect nicely at Whitefield EMR. And don't forget to tattoo. So the technique, using general basic principles, move your patient around to get the lesion into the best possible position. So usually that is going to be at around 5 o'clock or 6 o'clock if you are resecting a polyp with a snare especially, or with ESD. But sometimes if you've got a small pedunculated polyp, it can be hanging down from 12 to 6, and that is also okay, as long as you have good access to it. Minimal insufflation is also critical. Many a time if you insufflate too much, the patient gets uncomfortable, and also it might move your lesion away from you. And have an important understanding of where the fluid is going to pool. And this is also important if you have a complication such as bleeding, or if you're going to look for the fragments after they fall off when you resect them, because you should understand that they will go towards gravity. And I can't stop stressing how much I love the distal attachment. This is the cap or the hood. It is very simple. You can even make it yourself. And it allows you to move the folds and get onto the lesion, and makes therapy so much easier. So moving on to cold snaring, this is my preferred cold snare. This is a designated skin snare called the Exacto by US Endoscopy, but you can get similar ones made by the companies. And this is almost monofilament. It's very thinly braided, and it is quite stiff and retains the shape. And when you close it, it works like a pair of scissors, which actually slices through the tissue quite easily. Snaring tips, so bring the lesion to your lower field, 5 or 6 o'clock. I tend to prefer to inject a drop of something underneath it, a bit of EMR or saline even, and that allows you to get a good margin. And then I crown the lesion with the open snare, and then close and cut. And while I'm cutting, there's no heat here, so you can apply downward pressure onto the wall with the wheels. Close the snare and cut. Your assistant can do that, and then aspirate into a polyp trap. So have a polyp trap ready, and wash and inspect the side just in case you need to apply some core treats. Highly unusual to need to do so. So in this case, I'm going to inject underneath the lesion. There's a bit much injectate here, but I don't mind as long as I get a clear margin. So that is our cold snare going onto the lesion. I'm pushing down, and I'm closing the snare quite firmly and cutting through, and you can see that the lesion is cleanly off. A bit of oozing always happens, but that is not important at all, and that is a safe cold snaring method. Moving on to diathermy, so you should know your diathermy, you should understand it. I don't mind which one you use as long as you understand it well. And most of the time, diathermy is a blended current. So it's not just pure cut here or pure coagulation. It's going to be a blend. And depending on which type of blended current you're using, you can modify how much coagulation there is inside or how much cut. So by playing with the duration and the interval, you are going to increase the coagulation vis-a-vis cut, especially if you are going to use a different effect. So for example, this is the same endocut, duration 2, interval 2, but changing the effect. And you can see that the thermal injury, because of more coagulation, is going to be greater. So be mindful of the effects of coagulation. Pedunculated polypectomy, this is the easiest type of polypectomy you can do if the peduncle is relatively small, because if it's larger, it might contain a vessel and you might want to ligate it before. So the technique involves you bringing it into your lower field at 5 or 6 o'clock, or sometimes even at 12 o'clock if you are able to crown it from below. Inject the stalk and consider the potential of there being malignancy in the head, the Haggett level, So cut 1/3 up from the bowel wall so that you'll be able to give your histopathologist a degree of submucosal stalk. So this is an example, and this is a tubulovillous adenoma, most likely with low-grade dysplasia. So we're injecting the stalk, and we're going to crown it with a small snare. So try to get it at your 5/6. Move down the stalk and resect, like so. I tend to close the snare myself because I prefer to be aware of what I'm doing. And you can close this or not. This one was closed because the patient was on anticoagulants. This is another lesion. We decided to resect this again after injecting by keeping it at the sort of 11 o'clock or 12 o'clock position because it was easier. I know that the fluid is on the bottom side of the screen, and close the snare gently. Again, this patient was on anticoagulants which were stopped, DOACs I think, which were stopped about 48 hours before, resected, and there's going to be a bit of bleeding here. So it is important to understand that you can use the tip of the snare to try to stop the bleeding, and that gives you time, especially if it's a bigger bleed. But I always like to close these things if patients are on anticoagulants. So then by applying a few clips here, we close the defect easily. And you can see the importance of the distal attachment and allowing us to do so effectively. If you've got a larger polyp, you should know how to use the endoloop. And I always tend to use an endoloop cutter so that after I place the endoloop, I trim the ends of the endoloop so that it won't come in the way if I had to resect it. And this is a large one I resected together with Professor Yamamoto at Düsseldorf live. In this case, it proved that when we applied the endoloop, we came too close to the head. And you have to recognize that, because if you are going to place an endoloop, it should be more down the stalk. So if you come close to the head, you have to either place another one, or better still, cut through the stalk using an ESD technique like we did here at this particular instance. Moving on to endoscopic mucosal resection, EMR. So this can be done either on block or wide field, piecemeal, meaning the preferred term is wide field because it recognizes the fact that it is quite a wide area. And the technique involves dynamic injection, so inject and resect, and don't inject too much, and resect accordingly. And another set of pictures from Michael Burke's paper from the gastrointestinal endoscopy clinics of North America. These are mistakes in injecting. So if you've got a jet sign, it fires through. There's no way you can actually resect this by a snare. This is very fibrotic underneath. This is a lesion that is suspicious for invasion, a non-granular lesion which is not lifting. Another mistake is injecting into the mucosa, which makes things much harder. And canoeing tends to occur when the area around the lesion lifts, but the lesion does not lift, and many a time this is associated with fibrosis. When coming to EMR, you have to have a strategy for the wide field. Take out the largest nodule in a single piece first and send in a separate pot. As I told you, if you've got a granular lesion with a nodule, the chances are that the high-grade dysplasia is going to happen there. And do not leave bridges or islands, because those are going to be the hardest parts to resect. And if you cauterize the margins and use cold avulsion of fibrosed areas, you reduce the risk of recurrence. This is an unblocked EMR, which I'm doing in retroflexion in the right colon. You can see that retroflexion allowed me to identify the lesion, especially with the distal attachment, and you can see the telltale sign of a sessile serrated polyp, a sessile serrated lesion, because there's a mucus cap. So I've injected it in retroflexion to bring it forward, and now I've de-retroflexed, and I'm continuing to inject a bit, and this allows me to understand the margins better. The snare is slightly too large for the lesion, but we're going to go ahead with it, and I grasp a clear margin around the lesion, and while squashing it, I resect, and in this case, I've decided to burn part of the margin, not because I'm suspicious. Wash to make sure that you haven't left anything around, and again, in this case, because the patient was on anticoagulants, I've elected to close the lesion. And this is quite easy, especially if you've got the distal attachment, to close the area of resection. Okay, so we'll place another clip here at the top and another clip at the bottom. And if you've got large lesions, especially in patients who are elderly or on anticoagulants, or it's important to try to close the lesion because it reduces the risk of bleeding. This is wide field EMI. You've got the schema here of what we're doing. So this is almost in the cecum in the proximal ascending colon. And this graphic was made by my colleague, Professor Jano, who was with us at the Royal Free from GT Medical University. We removed the large nodule. There's a bit of bleeding, which we will deal with later. And I continue to resect the lesion in a jigsaw puzzle-like fashion, so trying not to leave any bridges. And if you do it systematically and quite orderly, you are able to resect it without leaving anything around. And then it is prudent to burn the edges using soft coagulation of the snare tip. So this is one of the last pieces coming off. We've controlled the bleeding with a clip. I'm going to burn certain areas again with snare tip coagulation, and that's the lesion off. And it's important to collect the pieces thereafter. There is some room, especially for fibrosed lesions or lesions that don't lift, for underwater AMR, as described by my good friend Kenneth Bin-Muller, and lesions float away from the muscle wall, and it's proven to be quite safe and allow for a high unblock resection rate, especially for flattened fibrosed polyps. Complications. So the risk of complications goes up if the Simpson score is over 4. Okay, and this also holds not just for bleeding but also for perforation and also for post-polypectomy syndrome, which is basically irritation of the muscularis propria from a combination of injectate and diathermy. And the bleeding can be separated into both intra-procedural, but more importantly into delayed bleeding. And this is especially true for large right-sided lesions, which is why I prefer to close these. And you need to know how to deal with your own complications. So if you have a jet spurter, for example, in the middle of a procedure, you need to understand gravity, you need to understand where it's going to pull to be able to allow you to close that with a clip. You can even transiently pause the bleeding by the application of pressure through a distal attachment, and also you can even apply some of these new powders, or better still, the beta pleated sheet self-assembling gel known as Puristat for these things. Have a water jet, think about gravity, change position if need be, use your adrenaline washes. And Professor Jano, the gentleman I've mentioned earlier, came up with an idea of creating a gel. So he used this gel. Initially it was a generic form, and now they've developed their own in order to create a barrier, a transparent barrier, whereby you were able to see the bleeding point without the blood mixing too rapidly with something like water, and that allows you to see the bleeding point accurately for you to be able to apply a clip directly. If you do have bleeding, try to achieve hemostasis. You can do this, as I showed you, with snare tip coagulation, with low forced coag or swift coagulation. You can also use a coagulation forceps and, of course, clips. And as I mentioned, hemostatic powders and the gel. Perforation can be either immediate, where you have to recognize it, even if it's not a full thickness, or delayed. The immediate tends to reveal itself if you look for the target sign or the reverse target sign. This is, for example, a large sessile serrated lesion which came off very nicely. And I always tend to look at the underside surface of the lesion, and lo and behold, there was the target sign. And that means that there's a bit of muscularis propria, which if you do not deal with instantly, may lead to a delayed perforation and the need for surgery. So if you understand that there has been a perforation during the procedure, deflate the colon a bit, Don't panic, shift fluid away to reduce the risk of contamination and give antibiotics. And as I say, minimize gaseous insufflation and start clipping. And usually you should start from the lateral aspects of the margin of the defect, because if you try to close the center, it's going to be harder. Give antibiotics, make your patient comfortable, some more sedation, and if you're still worried, you should definitely contact your surgeons, and I almost always admit for observation even if I've closed it. And these are some examples from one of Michael Burke's paper of the target sign and the hole and closure of the place after the procedure has been completed. Delayed perforation, well, this is a bit more nasty and usually tends to require surgery, so the critical thing is to give antibiotics and analgesics, but most of the time this is what you're dealing with. So this is fecal peritonitis in the context of a perforation, and that was the perforation. What is post-polypectomy syndrome? Well, this is a pre-perforation, so it's usually a bit of peritonitis caused by the injectate and diathermy of the muscle wall. You need to admit, scan them, but many a time you can manage them conservatively with intravenous antibiotics, analgesia, and clear fluids. And do not forget to tattoo, okay? Because marking for surveillance is important. So this is the example. So you put a bleb of saline first just to find the submucosal plane, and then you ask your nurse to swap the tattoo while keeping the needle inside the area that you've pre-prepped with saline, and you'll see a swift color change into this black-green discoloration, and that is the tattoo, and that is the right way to do it. I usually tattoo distally about 1 to 3 centimeters away from the lesion. So for this part of the talk, understand the lesion, refer on outside your skill set, consider the whole picture and prepare carefully, and use the most appropriate technique for the situation. Know how to deal with your own complications and have surgical backup. And don't forget to mark your resection site for surveillance. Moving quickly on to ASD. So I need you to understand the perspective here, because we talk a lot about unblock resection and ASD and even EMR, but you have to understand that only 5% of the lesions that we encounter at colonoscopy are sessile and over 10 millimeters. So this is really what we're focusing on when we're talking about ESD and the like. So this lecture will focus on unblock resection, and it is evidence-based. So when will we be doing this? Why should we be doing this, and how? And then I'll summarize for the last bit of my talk. So again, paraspecification is critical, understanding, and we're going to talk about these lesions, which are most of the time when you would resect. Why? As I told you, Michael Burke has shown us that these are the puppies, even though they're very big, they're very benign, they don't have much high grade inside them. And if there is going to be some trouble, it will be in the nodule, which you can take out separately in one piece while resecting the rest of the lesion piecemeal. However, these are the nasty ones, and these are the ones we should focus on unblock resection for. Why? Because the risk is high in those areas. So this is a benign lesion, which is suitable for piecemeal endoscopic mucosal resection or wide field EMR, granular, large, low risk. And even though we can resect it, and we do resect it, and the piecemeal EMR or wide field EMR is very quick and safe, and most of the time all those pieces contain low-grade dysplasia, one has to understand that even if it's done correctly, it can have a recurrence rate of up to 20%. And this dictates close surveillance intervals, as I showed you before, so it's not without burden. And if there is a recurrence, it will be a very challenging recurrence in the context of fibrosis. And plus, if you find an area of high-grade dysplasia, your histopathologist cannot tell you where that area is. So these are the disadvantages of wide field EMR. So a lesion like this, for example, is unsuitable for wide field EMR. Why? Because it has a high risk of high-grade dysplasia. So it should be removed by ESD. All right, and going back to the Jaynette, important to understand that this is the type of lesion which we would be removing by ESD, where we're suspicious for high-grade dysplasia, because if it's this one, it's already gone beyond resection and needs to be sent to the surgeons. And this is a diagram which also describes what I showed you before about non-granular and the risk. We talked about this, so SM1 usually is the best one, or up to which area we go for in terms of resection, ESD, because the risk of lymph node metastases is very small. And you hear your surgeons arguing in the background, but colorectal surgery is just as good. We can remove this by laparoscopy. Well, even with laparoscopic surgery, there are always higher risks. So a higher risk of mortality, morbidity, even with laparoscopic surgery, for example, a right hemicolectomy, there is still an effect on the quality of life with diarrhea and the like. And plus, it is much more expensive and needs more resources. The downside to endoscopic resection is that we have a slightly unknown risk of lymph node metastases if there is submucosal invasion, and there is also a risk of perforation and incomplete resection. But with our improving techniques, these two risks are lower. And when you argue with your colonic surgeon, a colorectal surgeon, you can also point out the fact that risks increase with age, particularly if patients are over 70, and there is a one-year mortality for over 80-year-olds of up to 29%, and this is well documented in the literature. And risks are many, including anastomotic leaks, bleeding, plus the thromboembolic disease, and also adhesions, among several others. So this is why we try to remove these lesions endoscopically and unblock by ESD. But before and the how, we need to evaluate the lesion very carefully. As I showed you, we need to correctly select our patients. We need to have a multidisciplinary team discussion, and we also need to achieve the appropriate consents by explaining risks and alternatives. You need to select your correct tool because there are several out there, and in my opinion, one should select or choose one of these tools. These are my preferred ones, the flush knife BT and the dual knife, because you can inject through the knife and speed up the process while also coagulating vessels. You should also use a coagulation forceps, or at least have it handy just in case there is big bleeding. My preferred method uses the hood. The ST hood is developed by Professor Yamamoto, my mentor, but there are several other hoods that you can use depending on the type of technique you are using. The injectate needs to be a bit viscous to lift the lesion off the muscle wall to make the procedure a bit safer, and this is the Sigma Visc, which is hyaluronic acid, which was developed by Professor Yamamoto as well. And you have to understand your diathermic settings. Most of the time we'll be using the yellow pedal to make the mucosal incision and cut to fibrotic areas, while we'll be using Swift Coag mainly for submucosal dissection in order to have a dry field, because this allows for some coagulation, especially of relatively smaller vessels. And although the principles of ESD entail us marking, injecting, and making a circumferential incision and then taking it off, we know that if we make a circumferential incision, we tend to lose the fluid that we've injected quite rapidly, and that holds true and makes the procedure more difficult, especially if we are not using traction like clip and band, for example. So our preferred method is the one developed by my GC colleagues, who have got a very close relationship with Professor Yamamoto and Professor Hayashi and Miura and their colleagues, and this is the pocket creation method. And the pocket creation method allows one to inject a viscous solution underneath the lesion by making a tiny incision. One ensures that this does not leak out, the fluid does not leak out, and instead of making a circumferential incision, one undermines the lesion by dissecting underneath the lesion. And once the dissection is complete, one can open the pocket first on the gravity side and then on the anti-gravity side and the lesion comes off. And there are several advantages. Number one, you can cut close to the muscle and it maintains a thick submucosal layer because a minimal incision prevents dispersion of the injected fluid. It keeps the direction parallel. It keeps the tip of the endoscope inside the submucosal pocket and facilitates tissue traction. And because you become part of the lesion, you are also able to remove any artifacts relating to respiration, which is great. This is the original hood, but there are certain developments which have created the new ST hood now, which is slightly shorter and wider, and this is what you see when inside. And to understand how deep you are in the pocket, you look for color change and you can measure the length of the tunnel. We have modified this slightly by the introduction of SITE, which is saline immersion therapeutic endoscopy, and the use of saline tends to assist in both opening the pocket, providing better views, reducing clouding and the artifacts relating to clouding, and it also allows us to use the buoyancy to lift the lesion and help us. And this is an example, a video example of resection of a large rectosigmoid lesion. I elected to resect this because in the rectosigmoid area, if there's a huge nodule in a sessile lesion, the chances of high-grade dysplasia are significant, as shown by Professor Burke. So this is us injecting, and very shortly I'll show you how we were dissecting underneath the lesion using, this is under saline, so saline immersion, making the incision. And once we make the incision, we'll get into the pocket. And you can see that the views are much improved with the use of saline, and with the buoyancy, the lesion is lifting away. And you can see how clear the views are, very, very clear. And if you've got some gas bubbles, they very easily escape, especially if you are using endocut rather than coagulation current. And you are very close to the muscle here, so muscle on the left and lesion on the right. And now the muscle is on the right and the lesion is on the left, and so on and so forth. And we can remove very large lesions with this method, and you get a very clear, clean, and R0 resection. And if you want to know more about the pocket creation method, Roya, our colleagues from Egypt, have recorded this excellent lecture by Professor Yamamoto himself, and it's available on their Facebook page in Facebook. So the advantages of ESD are that it has a high R0, meaning a complete unblocked resection, and this reduces the requirements for surveillance and gives the patient a degree of reassurance, especially if the cancer has been resected entirely. Of course, it has less morbidity than surgery and it's safer, but the disadvantages are that it takes a long period of training and it's got a long learning curve, and especially during training, there is a higher complication rate, and it still takes long. And the time of the procedure, when it starts going above the 3-hour mark, 4-hour mark, especially if you're using general anesthetic, can have risks for patients. So do not underestimate the risks associated with the long procedure. So I hope I have shown you that most colorectal lesions are amenable to resection by simple measures, and that the granular LSTs without a large nodule are very suitable for piecemeal EMR. But when you have a high risk of high grade, it's best removed en bloc, and that is the role for ESD, as well as when the lesion is fibrosed and when it can be difficult to resect it by EMR. And remember that it's no shame that if you cannot resect a lesion yourself, please refer on to who can. I should thank my team, and especially our newcomers, Dr. Alexandros Skamnelos and Dr. Rosio Chaki, and of course my very good friend and colleague, Dr. Alberto Moreno, who's my doppelganger, and our friends from GCHI, including Professor Yamamoto himself, Professor Hayashi Miura, and also Professor Yano, who are very, very good friends of ours. And We have an exchange program whereby we go to them and they come to us on a regular basis. I would have invited you to our masterclass, but sadly this year it's been affected by COVID, so I'm not sure whether we would be able to hold it. Almost certainly not, actually. Whereby we would have taught you the pocket creation method with Professor Yamamoto hands-on, but we can look forward to more exciting times ahead, I hope, after the pandemic is over. Thank you.
Thank you very much, Edward. Great talk. You were so balanced from one point to another. And I think that we have a great audience. We have about 68 active connection points. So that every connection point could have 2 or 3 persons. So it multiplies it as you can understand it. And well, it was an attempt of talk about complications, about the best therapeutics, the best diagnosis. So I think it was a very nice talking. We had an audience from North, South, and Central America too. We have even with us the president of the Venezuelan Society of Digestive Endoscopy, Dr. Joraima Montilla. She's among the audience. And we have professors from Brazil. We have Alex Oliveira. We have professors from all the Americas. And I think it was nice talking with you. Tell me something. From now on, we will have maybe question and answers activities. And I think the audience, actually, we have got still 62 persons. Okay, we can use the system of characters by using the chat, or you can also, by talking, making questions to Professor Despott. Okay, here comes the audience.
Thank you, Victor.
Okay, tell us something, Edward. What do you think from the endoscopic techniques and devices? Which one could be better, in your opinion, in order to the diagnosis of flat lesions? To change the color of the light, or to change the definition of the light?
Thank you so much, Victor. That's a good question. I think the answer is a combination of both, because high definition has become the gold standard. So to be honest with you, it should be a sine qua non that we are using high definition scopes nowadays, because it allows the proper characterization. The addition of contrast, be it indigo carmine or electronic chromoendoscopy, like blue light, for example, and nowadays even the magenta and sort of amber colored light. So the magenta, the lavender color is LCI, made by Fujifilm, while at the same time now Olympus have developed their own type of yellow-red light, which is proving to be not just good for lesion characterization, but also for detection. So to answer your question, I think we need both. More importantly, we need high definition, because with high definition light, even if you don't have a different colored light, you can use a bit of indigo carmine. And then, of course, if you combine it with electronic chromoendoscopy, it becomes easier.
Okay. Let's see if we have more questions in the audience. Dr.
So, Victor, I think Asador, we're going to ask questions.
Excellent lecture, Edward. It was very interesting. I realized by your videos that you routinely use adrenaline when you inject for EMR.
Yes.
That is despite the site of the lesion. In outside of the rectum also, you routinely use adrenaline.
Yes, I use adrenaline because it is something that allows me to have a dry field. Now, Of course, there is no real evidence out there. There's no randomized controlled studies that are of significant power to allow us to draw a line underneath this, to be frank with you. But I think it's a reflection of how you were taught. I think as long as the concentration of adrenaline is very dilute, so we use 1 in 200,000, so it's minuscule. It may, and I say may because there is no evidence, allow to get a drier field. So for example, when I removed that polyp, if you remember, that was at 12 o'clock, and I said, I'm going to resect it at 12 o'clock. There was a bit of bleeding. But if you saw, the bleeding happened very gently. It was like almost in slow motion. And it allowed me to actually put the tip of the snare and hit it. So there is this possibility, albeit not really proven. The anecdotal evidence supporting the use of adrenaline is that if you're going to have a bit of oozing, it will be less quick and you can actually treat it. But the reality is, as a though, that there's no right or wrong. Some people would prefer not to use adrenaline so that if the bleeding is going to happen, it happens immediately while they're there in front of them so that they'll be able to treat it when it happens, you see.
Excellent. Thank you.
Thank you. Lex, yeah.
Dr. Lex.
Hi, Edward. Excellent.
Hello.
As
Thank
always.
you.
As always.
Thank you so much.
I want to know about you about hybrid dissection, hybrid technique, and you do an incision around the lesion, and then you pass a snare. What do you think about this?
Yes, thank you, Lex. That's a very good question, and thank you for coming to the webinar. For sure, it's a great honor and a pleasure to have you here. So I think that there is a role, we call it knife-assisted resection, when you are not going to do a complete ESD, but possibly because you lack the expertise or you don't have the time, because it's much faster to use a snare, you would like to sort of get the best of both worlds. Now, if you do it correctly and if the lesion is favorable, then of course it makes a lot of sense, but you must not just dissect the mucosa, you need to actually create a bit of a groove within the submucosa itself as well. Otherwise, the snare may slide off. Now, there are two potential disadvantages to hybrid technique, and these are very much pointed out by Professor Yamamoto, my mentor. Number one, that if you have potential submucosal invasion in the center of the lesion, with a snare, you can just slice through that, or worse still, if there is muscle retraction with the tenting of muscle into that area, you can slice through muscle. Whereas if you are doing it with ESD and you are looking up close and personal at that area of tethering, you can actually dissect. Professor Yamamoto calls it climbing Mount Fuji, meaning you actually dissect the fibers, go up to the tenting and then down again. Whereas the snare, being blind and ignorant, will slice through either the fibrosis, the muscle, or the invasion. So that is the disadvantage. Through my experience, because I occasionally get tempted to use the hybrid. I had a recent case, for example, where I was resecting a scar. So someone had removed a small neuroendocrine tumor in the rectum, thinking that it was nothing, with a cold snare, incidentally, and it created a huge degree of fibrosis. And then they sent the patient to me for resection of the scar. So resection of a fibrosed lesion is already difficult, let alone resection of a scar. And we tried to get underneath it, and it was very difficult. So I said, I'm going to cut my losses. I'm going to take the aerial route, and I tried the hybrid. And what happened is, yes, we resected it, but the snare sliced through the periphery and left the center stuck down.
Yes.
We still managed to resect it, and it was an R0, and we got the few cells that were remaining from the neuroendocrine tumor in the center. But it just demonstrated the limitations of the hybrid technique. So yes, it's quicker. Yes, it's probably easier, but there is the risk of leaving the center of the lesion not completely excised.
Thank you. I totally agree with your opinion. It's my opinion too.
Thank you.
And I want to do more question. Last one. Do you have experience with acetic acid in to see clear the lesions?
Serrated
like
lesions?
Yeah, pit. Oh no, like pit pattern 3S and 5I. I think it's very good when you do acetic acid 2%. It's my experience, but I don't know.
Yeah. So I tend to there was a paper published by a group, a different Yamamoto, Katsumi, showing that it's very, very useful to highlight these sessile serrated lesions. It has a particular affinity, I think, because of the intrinsic mucus. It can also be used for adenomatous lesions, but I find it particularly useful for SSPs. But yes, I think it's an area of very exciting study, which goes to show that a very simple solution like vinegar, because that's what it is essentially, can highlight areas of suspicion and allows detection. And that's a very exciting study to do in general. It's been shown to be very useful in Barrett's esophagus. It was borrowed from the gynecologists who are using it for cervical intraepithelial neoplasia, the aceto-white reaction, and now it's proving itself very useful in all aspects of digestive endoscopy. So yes, very good question.
Thank you.
Thank you very much.
Okay. Do we have more questions from the audience? Let's see. Well, Edward, I think it was an amazing talk for tonight, and thank you very much for your expertise and your nice talking. And I think that in some new opportunities, you are going to be in our house too. Okay, you're going to be again in our meetings. And now Dr. Jaynette wants to say goodbye to the meeting.
Thank you so much.
Well, thank you very much. Thank you, Víctor. Thank you, Edward. Muchas gracias a todos por haber estado presentes aquí. Realmente fue muy interesante la charla de Edward. Y bueno, una vez más, estar todos juntos transmitiendo, enlazando desde Venezuela con Parodi, con Guillermo en Uruguay, transmitiendo para Facebook y para YouTube. Realmente son muy lindos estos webinars y dejan muchas enseñanzas. Thank you again, Edward. Hope to see you soon here in the Americas. I don't know when or where, but you are cordially invited. So thank you all.
So much. Thank you.
Bye-bye. Good night.
All the best. Bye, ladies. Bye. Thank you. Bye, Victor.
Bye.
Bye. Bye.